biopsies of peripheral pulmonary lesions with various methods. And rarely less invasive flexible bronchoscopy procedures can also cause these complications. I'm going to tell about that also. And rigid bronchoscopy, again, I'm not touching upon because mostly diagnostic rigid bronchoscopy does not result in these complications. Therapeutic can, but we are not discussing it right now. So this is data from our center of about 10,000 flexible bronchoscopies, and we summarize the complications. This was a systematic prospective collection of complication data, and we found that the pneumothorax incidence was less than 0.5%. And if you assume that all pneumothorax were resulting from TBLBs, then out of the 1400 TBLBs, we had a 3% incidence of pneumothorax. Now, TBLC at our center, we have been performing it for the past about maybe a decade. And a recent analysis from our center shows that out of the 230 cases that we have looked at, there are 46 pneumothoraces. So, a rate on a higher side, that is about 20%. You can go very close to the pleura, but still avoid it. Then keep it slightly away from the pleura, maybe about 10 millimeters while doing a TBLB or a TBLC. Avoid the upper lobes if possible. If it's a diffuse disease, better go to the lower lobes. Optimize the number of biopsies, because in our study we also found that higher the number of biopsies, the incidence of pneumothorax tended to be higher, although not statistically significant. Then cryoprobe size, there may be a debate, because in that systematic review they found a larger probe was causing more pneumothorax. But some experience from some of our friends is that if you have a smaller cryoprobe, if it's a 1.1 probe or a 1.7 probe, it may go very close to the pleura and cause a higher incidence of pneumothorax. So I think the jury is still out whether a smaller or a larger cryoprobe results in a higher incidence of pneumothorax. Again, freezing times, we don't have much data whether a freezing time during a cryobiopsy affects the rate of pneumothorax. So now we come to the remedy. So the first thing is early detection. That can be done with fluoroscopy immediately after the procedure. For example, if you're doing a TBLC or a TBLB with fluoro, you do a pneumo check with a fluoroscope immediately if you're using fluoroscopy, and be sure that you look very carefully, because sometimes a very subtle line will appear which will tell you that there is a pneumo. Always do the cine mode as well as the freeze single shot mode, because sometimes a pneumo can be identified in only one of the two modes of fluoroscopy. Then you have lung ultrasound. So if you have a absent sliding pleura sign, or if you have a barcode sign, then you can identify a pneumothorax. Now, what is the sensitivity and specificity? It varies over studies. So if you look at hypoxemic individuals and you evaluate with an ultrasound of the lung for pneumothorax, the sensitivity is very high, because there you already have a symptomatic individual in whom you are looking for that. But with post bronchoscopy pneumothorax, as the pneumothorax can be delayed, the sensitivity can be as low as 68%. Also because it depends on the operator and because of the delayed pneumothorax. So this is the most common air leak that we encounter in our practice of diagnostic bronchoscopy. But there are rare things in this world and rarest of the rare things in this world. For example, these are bismuth crystals, which are very rare and which form beautiful patterns in the shape of a rainbow. This is a dragon blood tree found in Australia. This is a beautiful spider, which is again found in Australia. And then you have this hand of Buddha. It's a fruit, again a very rare fruit. And this is a white peacock, rarely spotted. So the last entity is air embolism. Again, it is a very rare phenomenon to occur with diagnostic bronchoscopies. It mostly occurs with therapeutic interventions. For example, if you're doing an ND-YAG laser, and if you mistakenly puncture a part of a vessel, it basically entails air entering the low pressure pulmonary venous circulation because of a pressure gradient, which then embolizes to systemic circulation and can reach the muscles and viscera, where it is well tolerated, but it can also reach the brain where it is not well tolerated. So it is classic. The classic presentation is that if you're doing a bronchoscopy, especially if you're doing a therapeutic procedure or even a diagnostic procedure, suddenly the patient becomes drowsy and you have no reason to suspect why he did so, or even unconscious or develops a stroke. So then air embolism needs to be suspected. There are very few case reports of air embolism. These are the two recent case reports I found. One was after a TBLB, conventional TBLB. The other was after a TBNA. And both these reports have summarized the literature, and we just have 6 or 7 cases each of air embolism occurring after TBNA or a TBLB. And they basically hypothesize that when you wedge the bronchoscope and the patient coughs, then there is a huge pressure created locally which can push the air into the pulmonary veins, which finally embolizes to the brain. So the management is suspect. So if you have these symptoms rapidly coming immediately after a bronchoscopic procedure, investigate, for example, with a CT angiography of the brain. So what you see in the brain is these specks of like black specks which represent air. You can also look at the retinal vessels on the fundus, and if you can identify air bubbles. Finally, you treat with hyperbaric oxygen if available. Otherwise, you just give oxygen supplementation and wait. So the management principles, I will not go into details because there are no guidelines or studies which can guide us on the appropriate management of an iatrogenic pneumothorax occurring after a small TBLB. What we have is a primary and secondary spontaneous pneumothorax, huge guidelines. The basic principle is that primary spontaneous pneumothorax, the lungs are healthy, so don't intervene. Try not to intervene. With secondary spontaneous pneumothorax, as the lungs are bad, you generally try to drain and seal with fluorodesis. Iatrogenic, it can be occurring in a relatively healthy lung. For example, if you have a very focal kind of few nodules, then it's a relatively healthy lung. But if you have a diffuse lung disease like an ILD or emphysema, then it's an unhealthy lung. So what to do? So I think we don't have the real answer, but I'll tell you our practice. So if we see a pneumothorax occurring after a TBLB, we go for oxygen supplementation if it's a small pneumothorax. We follow the old principles of having 15 to 20% of the hemithorax semi-quantitatively assessed. And if it is more than 15%, we go for a single time aspiration with a cannula. Then if it is any size but with hypoxemia or severe breathlessness, not attributable to any other reason, then we may place a chest tube. If there is failure of single time aspiration, again a chest tube. Or if there is a large pneumothorax, when we do the X-ray, then we do if it's more than 50% of the hemithorax roughly, then we directly put in a chest tube. A prolonged air leak is very rare after a small TBLB or TBLC, unless it's a very bad lung. And if the chest tube leak prolongs beyond 5 days, then you intervene. Again, we have a talk tomorrow, I think, where the surgeon will come in and tell you about leaks and bleeding. So the take-home message is air leak may result from diagnostic bronchoscopy procedures. Pneumothorax most common, but pneumomediastinum and subcutaneous emphysema are rare, and air embolism also is rare. So the general average rates are TBLB 3% of 3% pneumothorax, TBLC 8%, PPL biopsy 2%, mostly without dire consequences. So you can avoid by practicing caution. Detect early by fluoroscopy or lung ultrasound. I didn't say because it was very obvious that all of us are doing an X-ray, a radiography, basic radiography 2 hours after the TBLB procedure. And treat using oxygen, aspiration or a chest tube. Thank you so much, and I cordially invite you to Chandigarh, where we are doing the second edition of Current Perspectives in Interventional Pulmonology in 2026, 27th, 28th February and 1st March are the dates. Please save the dates and try to make it to Chandigarh.